Hello friends, welcome to Next Fellow. I'm Dr. Narendra and today we are going to discuss hemorrhoids. Hemorrhoids are normal vascular cushions and they are present in everyone. But when we use hemorrhoids, we mean symptomatic hemorrhoids. There are two types of hemorrhoids, external and internal. External hemorrhoids, they are related to inferior hemorrhoid plexus surrounding the anal wedge. They are not true hemorrhoids. External hemorrhoids present as sudden onset painful swellings at anal margin. They usually present after straining at stool, coughing or lifting heavy weights. It's a self-limiting condition. It separates fibrosis and later forms skin tags. Or if they present early within 48 hours, we can evacuate the clot under local anesthesia. Internal hemorrhoids result from enlargement and protrusion of anal cushions. These are true hemorrhoids. These are present in 3 o'clock, 7 o'clock and 11 o'clock positions. The key etiological factors include constipation and prolonged staining. Or it can be secondary to other causes like carcinoma anorectum. This is not common, but it's very important. You should not miss them. Other causes include rectal deformities, conditions that increase abdominal and pelvic pressure like ascites, pregnancies, pelvic organ neoplasms, and neurological conditions. Pathophysiology of hemorrhoids. Due to constipation and prolonged straining, the shearing forces lead to caudal displacement of anal cushions and mucosal trauma. With time, fragmentation of supporting structures lead to loss of elasticity of cushions and they no longer retract following defecation. Coming to symptoms of hemorrhoids. Bleeding is the commonest symptom of hemorrhoid. The bleeding in hemorrhoids is characteristic. It is seen separate from motion and usually seen on toilet paper on wiping or as fresh splash of blood on the pan. Pain is uncommon in hemorrhoids. It's present only after mass prolapses below the dentate line. Patient complains like they are passing ground glass. Other complaints include itching and pile mass during defecation. Basing on the symptoms, we can grade hemorrhoids. Basing on the clinical features, hemorrhoids are classified into 4 grades. Grade 1, only hemorrhoidal bleeding and no prolapse. Grade 2, hemorrhoidal prolapse is present but it reduces spontaneously. Grade 3, it does not reduce spontaneously, we have to do manual reduction. Grade 4, hemorrhoidal mass cannot be reduced. Management of hemorrhoids. The first and foremost, the most important thing is we have to exclude other causes of rectal bleeding, especially colorectal malignancies. And then we have to help in behavioral therapies. That is, ask the patient to avoid straining and limiting the time in the toilet. And we can use stool softeners and bulking agents to help in defecation. In whom medical therapy fails and in grade 1 and grade 2 patients and grade 3 select patients, we can give some office-based procedures like rubber band ligation, sclerotherapy and infrared coagulation. Here we can see rubber band ligation. Rubber band is ligated to pedicle of the hemorrhoid and then after 8 or 10 days the hemorrhoidal mass sloughs off. Similarly at the pedicle we can give sclerosant and the hemorrhoidal mass fibroses and mass reduces. Excision hemorrhoidectomy can be offered to patients with grade 3 and grade 4 hemorrhoids and with symptomatic combined internal and external hemorrhoids with prolapse or for patients with substantial associated skin tags. Either open Milligan-Morgan or closed hemorrhoidectomy, that is Ferguson, can be performed. Both are similar in that mass is excised and pedicle is ligated. The difference is in closed, we suture the edges. Postoperative care after hemorrhoidectomy should be aimed at maintaining regular bowel functions. Laxatives are used. Pain is managed with sitz bath and analgesics. The complications are, early complications include pain, acute retention of urine especially in males and reactionary hemorrhage due to slippage of knots. The late complications include secondary hemorrhage, strictures and incontinence. Other treatment options for hemorrhoids include stapler hemorrhoidopexy. We use specially designed stapling device to create mucosa to mucosa anastomosis. In this, we are removing additional mucosa and submucosa which is prolapsing and device anastomosis both the edges. All this procedure happens above the dentate line, so it's less painful and early results are as good as hemorrhoidectomy. The disadvantages include long term the recurrence rate is higher and then there is a risk of rectal perforation. Other treatment options include Doppler guided hemorrhoid artery ligation. Here, feeding vessels of the hemorrhoids are identified using handheld Doppler and then they are ligated. Since all the procedure happens above the dentate line, it is also not painful and there is no risk of perforation. But we might need to do additional mucopexy in large hemorrhoidal prolapse. So that is hemorrhoid.